دراسة يا دكتور إسلام في أيرلندا، ها؟ شكلك استقريت.
Thank you. Just give it one more, few more seconds to be exactly at 8.
Will we start recording, Prof. Saad?
Just give few seconds.
Okay.
I'm quite conscious about time. You can go, Dr. Hisham, now.
Okay.
You can go, Dr. Hisham.
Okay, so welcome everyone again to the mega online course, to the very big dream and idea that started long time ago for the benefit of our colleagues and the benefit of everyone. Welcome everyone again to a new session with new titles of the mega online course with our eminent speakers today. And I will let the moderators to take the mic to present the speakers one by one. I wish everyone today a very useful and fruitful night with our speakers. And I would like to thank everyone who will attend, and first to thank our speakers and the mic with the moderator.
Okay, thanks, Dr. Hisham. Bismillah ar-Rahman ar-Rahim. Good evening, everyone. First of all, I would like to thank the organizing committee of MEGA Online Course and the MEGA Medical Academy for giving me the chance to be a member of their family today. Thanks to all great speakers, attendees, and panelists. Actually, I saw that the course is very beneficial and fruitful. He giving us lectures from all over the body, all over the world, without moving an inch, while staying at home. I am so proud today to introduce my professor, my talented and famous Professor Samir Al-Ansari. Professor Samir Al-Ansari is a professor in the intensive care medicine at Ain Shams University. Professor Ansari is a great contributor to this course. He is a cornerstone of the success of this course. Today, he will continue his series on nutrition in the ICU in critically ill patients. Our title today, Trace Element in Critically Ill Patients. Dear attendees, prepare your questions and send me back to be answered at the end of the session. Professor Ansari, mic is yours.
Bismillahirrahmanirrahim. Thank you, Dr. Basma, for this nice introduction, really.
Merci.
And today I am going to complete my series of lectures or summary about the nutritional support in the ICU. Today I am going to speak about important item in nutritional support for critical ill patients, which is a trace element in critical illness. And I'm going to answer some questions related or regarding trace element administrations for our patients. What is the trace elements and what time I have to start trace element support? And if this trace element must be given for every patient in the ICU or for certain patients, and what is the rule of it and what is the beneficial effect of it? And if there is any interactions between the trace elements administration. Also, we have to know and to be oriented with some side effect of toxic dose or excessive dose of trace element administrations. All of these questions and other questions I have to answer it through this lecture. Supplementation of trace elements in critically ill patients should be considered, especially for extensive burn or for patients suffering from severe trauma, especially in the early time of admission to ICU. Because by time the mitochondria lost its functions and becoming to deteriorate, and so within 48 hours, if we not support these intracellular organelles, we will face some problems in our patient. Trace element really defined as the less than 1 part per million of body weight, very small amount of volume inside the body. And we have some trace element which is macro trace element and measured in milligram, and the other trace elements, micro trace elements, which is measured in microgram. The common or the famous trace elements which we face in ICU: zinc, copper, manganese, selenium, iron, iodine, chromium, and molybdenum. All these are essential for the patient. The micronutrients involve both trace minerals and vitamins, of course. And during our support with nutrition support to the patients, we give the micronutrient to the patient. We must not forget the vitamins and the trace minerals, which include trace minerals, macro minerals like calcium, magnesium, and phosphorus and sulfurs, and also the vitamins and the trace elements which involve the essential and some of the potentially essential trace elements. Micronutrient functions, it has really many functions. Addition, not just nutritional support for the patient, but also it is mandatory and important for the anabolism and for the biochemical reactions inside the body. And most of the trace elements which we give to the patients are cofactors for many enzymes inside the body, or for many enzymes which are involved in metabolism of lipids, proteins, and fats, and carbohydrates. It has a good role and a special role in immunity, especially for both humoral immunity, like immunoglobulin production, and also for cellular immunity through macrophage, neutrophil, and lymphocytes, and so on. Regulation of gene expression on and off, it is acted and facilitated by trace elements. Also, the antioxidant effect, very important and mandatory action of trace element. It potentiates the action of glutathione peroxidase, potentiates the action of catalase, potentiates the action of superoxide, and so very important in antioxidant defense mechanism for getting rid out of free radicals which are destructive to tissues, which makes the patient stay long time in the ICU, which is predisposing to severe catabolism and long time of persistence of catabolism or persistence of the inflammatory state. Also, it has a role for prevention of chronic disease. And so a trace element, as we will see, very important for critically ill patients. The appropriate route and the dose of the trace elements may be difficult really, and we depend on many measurements, minimum dose and the recommended daily doses, as we will see, and the maximum dose. And in some situations, in severe critical ill patients, sometimes we give the maximum dose to hasten the recovery of the patient as in severe pain. Also, for intervention, it is better to be started early at admission to prevent the progressive inflammatory state. Because any oxidation in the body really predisposing to more tissue destruction, more inflammation and vicious circuit, and more cytokine regeneration, and so on. Micronutrient supplementations, mostly in the ICU, we apply it empirically, not dependent on lab investigations, because as we will see, it's lab investigation or estimations in the serum and so on may be difficult in some states and may not be available in all the hospitals. Monitoring micronutrient very essential, as said, because the critical ill patient subjected to some disorders after admissions, especially in absorption. The patient may be becoming edematous, the absorption may be impaired. Some patient may suffering from pernicious anemia, bariatric surgery, inflammatory bowel disease, celiac disease, inflammatory bowel disease. All these impair the absorption of the trace elements, and so may pushing us to support the patient with trace. Some conditions lead to loss of trace elements, like inflammatory bowel disease, fistula, fistula, very important in fistula, in exudates and in severe burn. You find the trace elements. If you measure the serum concentration after burn, you will find it dropping, although the tissue or the exudates are rich with these trace elements because of shifting of trace element from the blood to the traumatized tissue and to the injured muscles and so on. Some of therapy directly depletes the patients of the micronutrients, such as renal replacement therapy, especially the continuous veno-venous filtration and the continuous veno-venous hemodialysis filtrations, really pushing the more of the trace element to the effluent fluid coming from the machine. For example, the copper we find in traumatized patient and in burn patients, you find it depleted rapidly because of aspirations, because through feces and urine, and most of copper loss in cutaneous, as I said, in cutaneous exudate. Also selenium, after major trauma, we will find it concentrated in the traumatized tissue, and the serum will be low in serum level in selenium. In CRT and continuous renal replacement therapy of renal problem, we will find also depletion of most of trace element. Trace element requirement really, there is too much controversy regarding how to establish the recommended intake. And the questions, we give lower than normal body stores, which may be adaptive and may be sufficient for some patients, or we have to give excessive doses, which may be indicated in severely traumatized and burned patients. Really, there is a gap in our knowledge regarding the basis of nutritional requirement and how much the optimum dose for the patients. And we don't forget the trace element is an inorganic molecules, and so the potentiality for accumulation and toxicity is present, and so we have to avoid excessive doses to avoid the toxic effect of the trace elements. And scientists really must produce new evidence for the optimum doses, which is not settled till now. And so there are many dietary reference intakes for or reference in value for the trace elements. The number one, estimated average requirement, or recommended dietary allowance, which we follow it mostly, and the adequate intake and tolerable upper intake levels, which must be given, as I said, to the most traumatized patient and extensive burn. Assessment of trace element status may depend on static indices. You can take sample from blood or tissue or plasma, or you can depend on functional measurements, which will depend on estimation of some enzymes, which these trace elements participate in its function. Serum, for example, serum and leukocyte level for zinc, serum and urine levels for copper, serum assay for selenium, and plasma iron and the transferrin and the ferritin level to assess iron store in the body. These are examples of estimation. Static indices really are of limited significance to reflect the accurate trace element status in critical illness. Measuring serum levels of trace element is difficult and require careful collection technique and special tubes for estimating the concentration of the trace element. Previous balance studies have demonstrated the unreliability of serum trace element levels. Serum levels may indicate recently administered trace elements and reflect short-term status, but don't accurately indicate the tissue level. As you know, the traumatized patient or critical ill patient is edematous, and the protein loss is too much, and the trace element shifted. Maybe the patient suffering from deficit trace element in the tissue, but in the blood may be optimum, and also maybe a trace element migrating to the exudates or through the fistula, and so on. The estimation may be not accurate indicator of trace element stores in our body. Functional measures, we can depend on some enzyme system in which the trace element participate, like leukocyte chemotaxis, like alkaline phosphatase, metalloenzyme, which zinc is participating and very important. Plasma glutathione peroxidase, assay for selenium, glutathione oxidase, which is important and mandatory enzyme for getting rid out of oxidative radicals. And so long as for example, glutathione, if the serum glutathione peroxidase is optimum in its concentrations, you be sure the selenium is in adequate amount in the patient body. Lysyl oxidase for copper, zinc, protoporphyrin, and heme ratio, and so on. We can depend on the enzyme system. This is an atomic absorption spectrometer block diagram to show us how we measure the trace element in the lab. We depend on a radiation source like xenon lamp or cathode lamp, and this is the sample here, and automatically subjected this sample, put it in a tube, maybe 0.1 mil and so on in the tube, and subjected to different temperatures, and the atomization and the wavelengths from atomizations may be calculated and detected through amplifier and signal processor after that. This is a diagrammatic representation of the machine used for trace element estimations in the tissue, in the blood. We can put the sample here in the tube, and this is a tube, small tube, graphite tube for collecting this sample. And we depend on typical setup of atomic, either absorption spectrometer or emission spectroscopy for measuring the trace element. Monitoring micronutrient, as I said, it is very important because both hyper and the hypo levels both are deleterious to the patients. Either the low level or the higher level will be harmful for the patient. Interactions between trace elements, there is an interaction here, there is some interactions. You may support patient with zinc or selenium, you will face him suffering from copper deficiency and so on. And even the site of absorption in the GIT depend on the type of the trace elements. The zinc, iron, for example, and selenium are absorbed mainly from duodenum and the jejunum, while the chromium and the copper are absorbed in the ileum. Zinc supplementation decrease copper absorptions and vice versa. And I think we saw some patients nowadays, especially in the COVID epidemic, some patients pushed to take too much zinc, and consequently they suffer from copper deficiency, and I will give you a case for this presentation. Iron administration also with intranutritional decreases absorption of copper and zinc, and can lead to zinc deficiency. So there is interaction between the different trace element in either absorption or in action. Altered bioavailability and the requirement of trace element during acute phase response during the early 2-3 days due to flow shift, due to altered regulation of acid-base balance and reduced dietary intake, decrease the absorption, increase the urinary loss, and alter the concentration of transport or binding proteins. And also due to the release of cytokine release or cytokine storm. All these factors really disturb and manipulate the bioavailability or alter the bioavailability of the trace element in our body. Factors which affect the trace element requirement, of course, the geriatric patients need more, malignancy need more of trace elements, hemodialysis, especially continuous replacement therapy, renal replacement therapy, peritoneal dialysis, gastrointestinal loss through surgical fistula and diarrhea, chylus leak and the fistula lead to large volume of protein-rich fluid loss and consequently large trace element loss. Bariatric surgery, parental nutrition in general need support or supplementation of trace element. In contrast to enteral nutrition, rarely we require to support with trace element. This is a trace element, as I said before, this zinc, copper, selenium, chromium, cobalt, iodine, manganese, and these minerals which we know, calcium, phosphorus, potassium, sodium, and so on. All of these are essentials for the body build and for enzyme action. And as I told the start, we have trace element, macro trace elements like iron, zinc, and copper measured in milligram, and the ultra trace element like manganese, cobalt, selenium, chromium, fluoride, and this measured in microgram. And also there are other which toxic trace elements like fluoride, lead, cadmium, and mercury, arsenic, lithium, aluminum, and these potentially toxic or toxic trace elements may be contained in some containers, and the patient may subject it, especially if he take some preferred formula from outside. The container itself may contain some of these potential toxic trace elements. We can summarize some of the excessive micronutrient intake or effects of excessive micronutrient intake, like for example, chromium. If increases more than 3 milligram, we will find spinal and joint degeneration and immunity problems. Chromium, as we know, very important in insulin actions, and its lead to insulin resistance. Copper, which is a hematopoietic factor, very important in blood formations. If exceeds 5 milligram, will lead to behavior problems, vascular defect, and infection, anemia, Wilson disease, as we will describe now. Iron will lead, if excessive dose, will lead to vomiting, diarrhea, metabolic acidosis, and hyperglycemia. Manganese may lead, if in toxic doses, to extrapyramidal symptoms. Selenium, also, if toxic dose, will decrease the deiodination and will lead to hair and nail discoloration. Zinc, which is very important in immunity, if increased, will lead to decreased immunity on the other side. Vitamin C, if more than 1 gram per day, may lead to renal problems and renal stones and cirrhosis. Vitamin E also may lead to increased mortality, and as we see, for example, vitamin E range, its dose range from 50 to 800 units of vitamin in diverse populations, and it depends on the patient condition and the extent of injury. Micronutrient monitoring, which must be indicated or must be important in the ICU, especially in some situations. Suppose the patient suffering from burn or TPN, he taking TPN, or subjected to renal replacement therapy, continuous renal replacement therapy, we have to measure selenium specifically. Zinc must be measured in severe burns, trauma, and TPN. Iron and ferritin of the patient suffering from anemia. Copper in the bariatric surgery, very important, and also in burn. Chromium if your patient suffering from insulin resistance and he receiving TPM. Manganese especially for home TPM. Also, don't forget some of the vitamins which are important, like pyridoxines in cases of macrocytic anemia and B12 and cobalamin in macrocytic anemia. Don't forget thiamine in cases of lactic acidosis, cardiac failure, and continued venous hemofiltration. I'm going now to speak about some individual trace elements in summary. A standard trace element formulation with the easiest and most economical means of trace element supplementation, which we use and we depend on it. Some package like multi-trace element for concentrations, multi-trace 5 trace element combinations, trace elements for cobalt plus trace element, and so on. The market is for with this, and Adamel and so on contains some trace elements which are standard package containing more than 1 trace element, and I think this is the easiest and easy method of administration of trace elements in the ICU. Except if you measure depend on lab investigation and you predict how much is the serum level, and you can supplement through individual trace elements, which may be expensive in some situations. Brand name for trace elements which may be available in the markets: Adamel, multitrace 4, multitrace 4 concentrate, multitrace 4 neonatal, multitrace 4 pediatric, multitrace 5 concentrate, and trace elements for pediatric, available many of the trace element, standard trace element concentration in the market. Adamel, for example, Adamel N may contain chromium, copper, fluoride, iodide, manganese, selenium, molybdenum, zinc, and so on. Multitrace 4 may contain chromium, copper, and manganese, and zinc, and contain aluminum in very, very small amounts, and benzyl alcohol, or maybe aluminum as a contaminant, not dosing adult trace element supplements. This is a summary for doses, how much you must give for your ordinary patient. Chromium from 10 to 15 milligram per day may increase to 20 milligram if there is intestinal fluid loss, and this is indicated chromium especially for diabetic patient and for facilitating the insulin action. Copper may be given from 500 to 1,500 microgram per day. Manganese from 150 to 800 microgram per day. Selenium from 20 up to 40 microgram and even 50 microgram per day. Zinc from 2.5 to 4 milligram per day, and consider increasing the dose to another 2 milligram instead in catabolic state if the patient suffering from extensive burn. Excretions of the trace elements mostly through the urine and feces and the bile. Chromium excreted through urine and bile, copper through feces, manganese through feces, and mostly all of them are through urine and feces. Trace element and functions is a summary. Immune system, if you want to potentiate the immune system, give copper, zinc, ferrous, and selenium. Energy production, manganese, if you want to increase energy. For hormone system, you have to give iron, manganese, zinc, and copper. For vitamin production, especially vitamin B12, you can give cobalamin. And blood productions, you don't forget copper, very important. Hemobiotic trace elements, very important. If it is deficient, the patient will suffering from anemia, and also give iron if the patient suffering from iron deficiency. If your patient suffering from enzyme system problem, zinc, copper, ferrous, and molybdenum. Skeletal system, you can give zinc and manganese. Reproduction, copper important, and manganese and zinc. This is another summary also. As I said, chromium for glucose metabolism, cobalt for component of vitamin B12, copper cofactor for cytochrome oxidase, fluorine present in bone and teeth, iodine compound of thyroid hormones, important for thyroid hormone production, iron present in heme pigments and in most of the pigments, myoglobin and heme, manganese a cofactor for many enzymes. Chromium, if we speak about individual trace elements, now we start by chromium, where doses we can give from 10 to 15 microgram chromium per day. Very important, its deficiency symptoms lead to glucose intolerance, ataxia, peripheral neuropathy, confusional state similar to mild moderate hepatic encephalopathy. After that, zinc is very important for formation of metalloenzyme like carbonic anhydrase, also for protein metabolism, for RNA conformation, and for membrane stabilization. It is very important for gene expression and gene on and off, enzymatic reactions, especially antioxidant, and immune functions, and for protein synthesis. Wound healing, very important. We give it sometimes in ulcers and in wound to hasten the healing, in growth and development. It is available in meat, seafood, dairy products, nuts, legumes, and whole grains. Contains high amount. Normal serum zinc level range from 70 to 150 microgram per deciliter. Total body zinc about 2 grams. 60% of the zinc in the body is inside the skeletal muscles, 30% in the bone, concentrated also in prostata and the hippocampus area, and so very important for neurological functions. And the recommended daily acquired dose is 10 milligram for adults. Don't forget glutein, which is a protein very important containing zinc and very important for taste sensation, essential for insulin, for storage of insulin and release from the pancreas, and also essential for vitamin A level in the serum. And I think zinc also, as we know, has some antivirals or hasten the recovery from infection with viral infection. Zinc deficiency lead to a characteristic syndrome or acrodermatitis enteropathica, which is inflammations around the acral area, like the mouth and the tips of the fingers and also the toes. And so very important to treat it by zinc, such these dermatitis conditions. Zinc deficiency, don't forget, lead to alopecia, decreased sperm and maturation, so important for reproduction, impaired healing of wound, and so very important in treatment of extensive wound and burn, loss of taste activity if there is zinc deficiency, and also it leads to impaired vision if it is deficient, and neuropsychiatric manifestations if we suffering from deficiency. Zinc functions again, it is a constituent and cofactor for more than 300 enzymes, and specifically the metalloenzymes like carbonic anhydrase, alkaline phosphatase, alcohol dehydrogenase, and superoxide dismutase. Zinc is essential for cell growth and for division, and for immune function, and the enzyme reactions, and the DNA synthesis and the protein production. Accelerates the wound healing. Zinc is commonly used in hospital as a treatment for burn, certain ulcers, and other skin injury. Zinc play a critical role in collagen synthesis and immune function and inflammatory response. It is necessary for proper healing. In fact, skin holds a relative high amount of about 5% of body zinc content. So zinc is really very important for many items and for many enzyme system, and we can use it in treating some refractory ulcers and also for wound, hastening the wound healing and so on. And so it reduces the inflammatory state. It reduces the persistent inflammatory states which can occur in some critical ill patients. As we know, some patients can suffering from persistent inflammation, or the second stage, the catabolic stage, may be extended for even months. And so zinc, one of the trace elements which hinder or stop this inflammatory state. Zinc is a component of superoxide dismutase. It is very important really in all the antioxidant enzyme in the body, glutathione peroxidase, catalase, superoxide dismutase, very important, and impair and hinder the changing of oxygen molecules to oxygen-free radicals. And as we know, oxidative stress leads to chronic inflammation, a contributing factor in a wide array of chronic illness, such as heart disease, cancer, mental decline. All of these diseases, which are long-standing diseases, a patient suffering from some existence of an oxidative state or inflammatory state. Zinc is beneficial in such states. Zinc is largely a protein bound, and so in the critical ill patients, due to loss of protein, it contributes to zinc loss and the deficiency of zinc. It plays a crucial role in cellular growth and replication and rapid epithelialization and wound healing again, and cellular immunity and protection against oxidative stress. Zinc play a key role in maintaining vision and concentrated in the eye, and maybe changes in the retina in patients suffering from zinc deficiency. Also, zinc is a gene expression and very important for working of the gene. Low zinc level can be associated with male infertility, sickle cell disease, major depression, and type 2 diabetes, and taste problems and insomnia, and so on. It appears to lessen the symptoms of rhinovirus, and so it has some antiviral activity. Zinc is essential for neurotransmitters and the melatonin formation, and so it plays an important role in melatonin formation and the sleep-awake cycle for the many patients, especially those suffering from insomnia. Zinc deficiency, as I told, lead to skin rash, ممكن lead to glucose intolerance, poor wound healing, hepatic dysfunction, diminished work capacity of respiratory muscles, and so on. And so 25 milligram per day of elemental zinc is usually recommended, especially in wound patient and burns patient. Normal serum zinc again from 70 to 150 microgram per deciliter. Low serum alkaline phosphatase may be used as an indirect measure of zinc deficiency. As I said before, we depend for our analysis for trace element or in general or for estimating the concentration, we can go through the functional evaluation of the enzyme system in which this trace element participate or sharing the function. Excessive prolonged zinc intake may lead to impair immune function. And so many patients nowadays really consumes too much zinc, and this is very dangerous. And I said one of the main problems, copper deficiency. Additional supplementation is indicated in critically ill patients, as I told, 25 milligram per day or 50 microgram per kg per day for parenteral dose, especially for pediatric. Don't forget some of the zinc compounds contains cadmium, which is very toxic and leads to renal failure. And so we advise to use zinc gluconate products more better and free of cadmium. Especially we see zinc toxicity in welders who inhale zinc oxide from their. The third trace elements copper, which is very essential and mandatory for wound healing, for hematobiosis, formation of red blood cells and bone marrow function, and for platelets formation, and also at the same time it is antioxidant and very important for connective tissue cross-linking. Copper deficiency may develop after excessive treatment with zinc therapy, and the patient suffering from anemia, neutropenia, and leukopenia, because as I said, copper is very essential for hematobiotic functions in the bone marrow. This is a case of copper deficiency, myeloneuropathy, and pancytopenia secondary to overuse of zinc supplementations. The patient, in summary, is 53 years old. He takes excessive doses of zinc, and after that, he made suffering from sensory and motor neuropathy in the lower limb and decreased vibration and proprioception sense. And the hemoglobin dropped, he is anemic, a mean corpuscular volume, white blood cells count 2.6, suffering from leukopenia, but normal vitamin B12, folate, immune functions. Brain and spine MRI show problem of copper deficiency. Serum copper was very low. It is 7 microgram per deciliters, normal from 70 to 150. Serum zinc is high, 2.28 microgram per ml. The normal range from 0.66 to 1.1, or just the patient treated with 2 milligram per day of copper, and he improved to some extent. Copper is very effective and important for connective tissue cross-linking, and this is very important. Copper deficiency led to pancytopenia, myelopathy, or peripheral neuropathy. Copper may lead to hepatic insufficiency, and so we have to decrease copper or even omit it totally if the patient suffering from hepatic problems. And we don't forget Wilson disease, in which there is liver problems due to excessive copper and the deposition of copper in the tissue, including the liver, and which lead to liver dysfunction, neurological disorders, and the Kaiser-Fleischer ring in the cornea. Copper is very important in burned patient. The requirement 5 milligram per day in adult and 20 microgram per kg per day in children. are necessary for compensations of cutaneous loss which occur in the oxidation coming from the burned area. This is a summary of Wilson disease, which develops from excessive copper, and those patients are suffering from enzyme deficiency ETB7A, which help or facilitate the combination of copper with ceruloplasmin, and this is an inherited disease, and if patient suffering from this genetic disease, he will suffering from Wilson disease, from copper deposition in all over the tissue of the body, including liver, brain, and kidney, and so leading to Kaiser-Fleischer ring, liver problems, also CNS disorders like dystonia and dysarthria, and dysphagia and mask-like face, and many problems related to copper, and treated, as you know, by penicillamine or chelating agents to decrease the copper level. Copper deficiency myeloneuropathy, which is evident here in these pictures. Here, there is problem here, and also in the brainstem. It is a constitute of selenium is a fourth trace element, which is essential for endogenous defense system against the oxidative stress, and this is the most important trace element as antioxidant in the body, really. Increases selective uptake of selenium by injured tissue for defense against reactive oxygen species may explain the progressive decline in plasma and urinary levels, because selenium is shifted from blood to the injured tissue, and the current recommended daily allowance for selenium is 55 microgram per day. Low plasma value are inversely correlated with severity scores in the ICU. When you see your the plasma value of selenium is low, you suspect the patient is highly in a critical state. Maximization of glutathione peroxidase activity, and so it is very important as antioxidant cofactor for enzymes which work as antioxidant, like glutathione. The requirement daily 60 microgram per day of selenium in trauma, 190 microgram per day in burned patient. Supranormal intake may lead to easy fatigue, irritability, neuropathy, and gastrointestinal symptoms. And of course, if your patient is supported by other antioxidant or other anti-free radicals like vitamin E, vitamin C, beta carotene, you will minimize the requirement of selenium as antioxidant defense. Selenium deficiency leads to cardiomyopathy, leading to congestive heart failure and arrhythmia. The other trace element, manganese, which is important in carbohydrate and lipid metabolism, and the manganese serves as a component of superoxide dismutase. Superoxide dismutase, one of the antioxidant enzyme, and is also important for arginine and pyruvate metabolism. Magnesium deficiency lead to carbohydrate and lipid defective carbohydrate and lipid metabolism, and lead to blood clotting defect and hypocholesterolemia and bone problems. Manganese is the enteral intake for about 2 milligrams per day, and while parenteral dose from 60 to 100 micrograms per day. Those should be decreased in patients with hepatic insufficiency. Manganese toxicity may lead to nausea, vomiting, headache, disorientation, compulsive laughing, or crying. Iron, as most of us know, it is very important as a cofactor for all energy metabolism, for oxygen transport, hemoglobin and myoglobin, and so on. Iron is a key component of the heme molecule and also other oxygen-carrying proteins, including heme enzyme, myoglobin, and cytochrome A. And as we know, transferrin is a transport protein for iron and binds to 2 iron molecules, transport iron to various organs and tissue. Serum iron plus total iron bound to transferrin give you the total iron concentration or in the circulation. Determination of transferrin give total iron binding capacity. And as the iron contains in green leafy vegetables, grains, pulses, liver, spleen, and meat and seafoods. Iron is a constitute of functional group of enzymes, importance in Krebs cycle, responsible for energy metabolism. Decreased transference duration in patients with major burn may lead to impairment of erythropoietin response, even in patients with normal level of erythropoietin. A decline in the cellular immune response occurs quite early with the onset of hyperinflammation and severe sepsis, and so we have to support the patient early. Also, mitochondrial dysfunctions may become irreversible 48 hours after the onset of severe sepsis. So early admission of trace element is important, and the optimum dose still now for reducing deaths due to oxidative stress is also not yet determined. The patient with increased serum zinc and copper concentration during ICU stay had significantly lower mortality. And some cases. Glutamine oxidation, very important for survival of human pluripotent stem cells, which is a source of other cells, ectoderm, endoderm, and mesoderm cells. Also, vitamin C is very important for even for vasopressors. As you know, it is a cofactor important for tyrosine hydroxylase, which converted to dopamine and norepinephrine and epinephrine, and so it is very important also to help to make proteins and decrease. Vitamin C can shorten the duration of the common cold, reduce blood glucose in patient diabetic, lower the blood pressure, open constricted airway, and so it is very important. In critical ill patient, you can go up with a dose up to 4 grams of vitamin C per day. Sometimes we give 1,500 in septic shock, for example. We give vitamin C in addition to thiamine, in addition to hydrocortisone, which potentiate the vasopressors and even hasten the recovery from requirement to vasopressors, and so it is very important. But normal persons need only 0.1 gram daily of vitamin C. But in critically ill patients need high dose of vitamin C, but take care of side effects like renal stones and so on. Vitamin B12, as you know, lead to combined degeneration if deficit, lead to anemia, megakaryocytic anemia. It is important to prevent depression and psychosis, and its deficiency lead to nerve damage and numbness and decreased energy production and so on. Cobalt is also very important in its deficiency, like vitamin B12 lead to same manifestations. And I think we have to stop here. And as you know, trace elements is a long topic. Nutritional support also is a long topic. I try to summarize the nutritional support and the trace element in these few lectures, or 3 lectures or 4 lectures, I don't remember. And if we have time, another time, we can support these lectures with another knowledge of regarding nutrition support. Thank you.
Thank you very much, Prof. Samir, for the very interesting lecture, as usual. And I will leave the mic to the moderator for the questions.
Okay, thank you so much, Professor Samir. It was an interesting and beneficial lecture. We are grateful for your time and the effort you took to share your thoughts and experience with us. Thanks, Professor Samir. And we will start our questions. The first question by Dr. Abdurrahman Yasser. How lack of nutrition can affect the patient rehab and safety in ICU?
Of course, nutrition is very important, as we said in the previous lectures. It is mandatory, and you have to select at first the route of your optimum nutritional support for your patient, and you have to consider underfeeding and overfeeding. Both represent malnutritional states, and you have to manage any deficiency in your patients from different ingredients, like either micronutrient or micronutrient. And all the complications you suspect from the nutrition support, especially you have to consider the feeding syndrome, for example, is very important to consider. Don't start your full nutritional support in malnourished patient. You have to start gradually. and also avoid hypoglycemia by withdrawing TPN gradually. And so complications, I think we mentioned in the previous lectures, it is many if you not give the optimum dose and the optimum selections of the ingredient.
Okay, thanks, Professor. Second question by Dr. Khalid Radwan. What are the empirical doses to be given to ICU patient for zinc, copper, selenium, or actual measurable values which estimated the recommended given doses?
These are questions which is till now very, very difficult, really, as I mentioned. The optimum dose for your patient, for ordinary patients, and for the critically ill patient, because it differs for both sides, for both patients. Till now not reported or not actually known, but I give, and you can revise the lectures and see there is a range of doses. Suppose your patients, if suffering from severe critical illness or severe trauma or extensive burn, you have to give the higher dose, the high recommended daily dose. If your patient is an optimum situations or moderate, you can give depend on the average dose. The normal patient may depend on the low dose, may be sufficient. And so the optimum dose till now, you can't assert really. It is a major problem in the ICU. But in general, I mentioned it in my lectures. You can return to the schedule which we put.
Okay. Question number 3 by Dr. Ann. Where we can measure zinc, would you recommend zinc empirically in all patients of ICU, or we can target a special population like patients with chronic heart failure and burns?
Mostly till now, and the easiest route of administration or easiest method of administration is the empirical administrations through using this standard formula which is available, which contains 4 trace elements or 5 trace elements, and it is the cheapest one which can be used for our patient in the ICU. If your hospital is equipped with spectroscopy and the facility for estimating the concentration of trace element in the blood, on serum, in the tissue, you can depend on it and you can give the accurate amount of requirement.
Okay. Another question by Dr. Asma. Role of glutathione in critically ill patient.
Glutathione peroxidase is a very important antioxidant enzyme in the critical ill patients, like mutilase, like superoxide catalase. It is a very important antioxidant enzyme for the critically ill patients. It prevents the formations of free radicals like superoxide and the hydroxide generated from the other ingredient, especially the oxygen molecules.
Okay. The last question by Dr. Amir Fouad. Different trace elements between enteral and parenteral in critically ill patient.
Mostly in enteral nutritional patients, we are not needing so much trace elements because mostly they receive a natural food which containing the trace element required. But suppose your patient is highly critical or traumatized severely, he needs some support or he needs some supplementations. But in TPN in general, all of the patients need trace element supplementation.
Okay, thanks, Professor Samir. It was interesting and beneficial and fruitful lecture. Now we are moving to Professor Dr. Ines Harou.
Thank you, Dr. Abbas. Thank you.
Thanks.
Good evening, everyone. Thank you very much, Professor Samir, for a wonderful lecture. Thank you, Dr. Basma, for being a wonderful moderator. First of all, I would like to thank Dr. Saad, Dr. Walid, and Dr. Hisham for giving us the opportunity to share in this wonderful group. This is an unprecedented chance for all anesthesiologists from all over the world to have free CME hours. And we need to give a disclaimer for everyone that these lectures are free. They are unpaid for. They are unsupported by any company or any organizations. And every one of us is very grateful to everyone in the Mega online course for their efforts. Now I would like to introduce our next presenter is Professor Dr. Yasser Reda. Professor Dr. Yasser Reda, he has more than 10 degrees in anesthesia. He is currently working as a consultant anesthesia and chronic pain management in Hamad Medical Corporation in Qatar. He is the head of PACU and intervention rooms for regional anesthesia and chronic pain interventions. He is the course director of ultrasound guided regional anesthesia and pain. He studied anesthesia and chronic pain management at the National Cancer Institute in Cairo University, Egypt, and was awarded his Doctor of Anesthesia and Pain Management in 2001. He has the degrees of the Arab Board of Anesthesia and ICU, European Diploma of Anesthesia, European Diploma of Regional Anesthesia and Acute Pain, European Diploma of Pain Medicine, mashallah. His certification for intervention pain sonography, Fellowship of Intervention Pain Practice. He has the ASRA Pain MSK ultrasound certification, Odon Therapy Diploma, the American Board of Headache, and he has published many papers in the field of regional anesthesia and pain medicine. He is the speaker and faculty in many local and international conferences and workshops in regional anesthesia. Professor Dr. Yasser Reda will be speaking to us today about the topic that is very important. It's called inadvertent intra-arterial injections of local anesthesia during cervical epidural. And this is important for each and every one of us as an anesthesiologist, especially with the increased practice of regional anesthesia, to get to know that toxic anesthesia can happen. Toxicity of local anesthesia can happen either local or systemic. And I will leave the mic to Dr. Yasser. Thank you very much, Professor Dr. Yasser. We are happy to have you with us.
Thank you, Dr. Basma, and I'm thanking also the army behind this work, especially Dr. Saad, Dr. Ali, Dr. Hisham, and the other member, because I don't know all the army behind this work. Also, I'm just proud to be part of this work, and I ask Allah as well to accepting our work. You know, my lecture came after will come after Dr. Samir, which is a heavy, delicious meal. So I will try to be a dessert for that. And you know that our science usually is tough. I try to be a little funny, and science is fun. Also, I'm just trying to cover this subject because I have a limited time. It is a lesson for me, and I want to share this lesson for everyone because it's very, very difficult lesson. And usually you learn from pain, teaching you and learning and changing you. So I will try to make my lecture as long as possible to cover the subject, and as short as possible to not to go to sleep and to get bored. So I ask you to fasten your seatbelt because I just try to get a little fast. So this is my beautiful city of Ras Al Bara. I'm also from Dimyata, and I ask all people just to come to visit this beautiful city. I don't have anything to declare about my conflict of interest. And you know, wisdom, no pain, no gain in life is not right for pain. If you have a pain, you will not gain anything. It may be just other pain in life, but not just our pain. You know, what we know and what we don't know about pain is like a tip of iceberg, and a very little information we get around pain. But you can look with concentration. This picture, this is not an iceberg. This is just a plastic bag. So it's still the same causes of radicular neck pain is the same, not changed a lot. The major cause is disc prolapse or foramen stenosis. It may be with technology, it may be changed in the future, but up till now the same. I want to just go fast about what's called the medication. You start usually by conservative management. Oral medication is a part, physiotherapy and psychotherapy. We have many medication, and we have a list of side effects of this medication, which is gastrointestinal, renal, hepatic, cardiovascular, and blood problem. And we'll just go about with psychotherapy is a very important integral part of management of this patient. Many other alternative medicine like stretching, aerobic exercise, essential solution. This lead to essential resolution of function of the body, of the muscle, of the joint, and some exercise suitable for your disease. And relaxation biofeedback is a very important part of the management. Some alternative like acupuncture, tense therapy, and all this stuff, massaging but if you get all this management variabilities, and at the end, you don't get a good result, don't get a toxic dose from the same medications, from the more conservative drugs. So can we offer the patient to get a relax, to get a quality of life after that if we fail all the medication? Yes, yes, we can. So this is a multidisciplinary pain management job. It is not a one-man show. It is a team leader or a team job, like a physician, pain physician, nurses, psychotherapist, neurologist, orthopedician, because pain is not treated by pain physician. If you have a cause, it may be treated by this to treat the cause. And sometimes the cause is beyond your scope of management. And I found in last year 3 books about speaking about the surgical management of chronic pain. So physical therapist is very important and very important part in some diseases is the crucial or cornerstone of management, and social worker to support this patient. So I'm just going very fast about that, but our patients, which this happened to me in the beginning of 2014, and I presented in many areas, international, national, because it's a very rare case. And when it happened to me, I was just, I get a mental block. I don't have any information what to do for this case. So our case was a female patient. It is the head nurse, the highest nurse for my hospital from Scotland. It was 55 years old, referred from spine surgeon, was the head of my team. She have a severe neck and radicular pain, shoulder pain and arm pain, numbness distribution mainly in C6 and 7 nerve roots. Bilateral, but more to the left, this pain. Not improved by conservative management at all, and this still have a severe pain affecting the sleep, quality of life, and not candidate for surgery because they have many pathology and multiple disc level, and this is the opinion of the surgeon. And she don't have a fever or weight loss. What I mean, not infection, not cancer, not red flag, and they don't have a history of cancer, because cancer patient with pain is cancer until proved otherwise. But cancer patient is not immune against other type of benign pain. She can get any type of pain. Nor other associated disease, not diabetes, not an disseminated disease for the nerve, disseminated sclerosis, no demyelinating nerve. When you just go like this, what do you need to know more about this patient? Really, it is not an interactive now, but just I will try to answer. Just you need to know what is the finding of MRI. There is a second ligamentum flavum, multiple level disc, mainly the compression to left side, and I found the nerve root affected in left side, because many patients you can write left compression and the pain is in the right. So don't consider that the MRI is not cornerstone for management. It means a cornerstone of exclusion. Because all the time I just go more diagnostic block. The diagnostic block may be more accurate than the MRI. No facet arthritis, no red flag, MRI shoulder, because sometimes the shoulder pain can confuse with the radicular pain. And shoulder pain usually nociceptive, not neuropathic. And it's again, the patient, if he can't sleep on the side of pain, this is more confirmation to be a shoulder pathology more than radicular pathology. Because muscle pain, you can't sleep with muscle pain, but you can sleep with nerve pain, even with severe nerve pain. So no MRI shoulder, no pathology, medial nerve, because sometimes the medial nerve confusion with a management which could give a great pain, and the patient wake up in the night from this pain, and sometimes it's confusing. What do you want to know more? I know that MRI is a very good tool because it can show the soft tissue, intervertebral disc, spinal canal, nerve roots, and surround soft tissue. But at the end, the MRI is a very good for exclusion, red flag, more than to diagnose. Because sometimes you found nothing and the patient still have the typical radicular pain. So a red flag is very important to look for it, because it can affect the management. And after that, I just go for coagulation profile, because this is a mandatory for the patient to go on the neck. INR, platelet, ABTT was normal, all things is normal, blood glucose normal, what BC is normal, liver and kidney function normal. What do you want to know more? What was the intervention to know what intervention I can do for this patient? And this is 2014, because if I get this case now, I will not do the same what I did 2014. So just to agree about this radicular pain, not relieved by any medication. So we must go for a further intervention management as a sleep bladder system. And because our management is not one fit all, so we have many options. You can make an intralaminar epidural, cervical, transforaminal, and there is a debate about transforaminal and selective nerve root block. If the time return back, now I make a selective nerve root block, because most of the time the problem in the neck is foraminal stenosis, not a central spinal stenosis. In lumbar, it is a spinal stenosis more than the foraminal stenosis. So very effective, and even the result now, because at that time the ultrasound for pain is not a big era. At that time, you know that it was an only option for me interlaminar. Why? Because transforaminal have two problems. From 2002 until 2008, they found about 28 case report immediate deaths after transforaminal epidural. And Hefner and his colleague, when he studied this, what happened, they found it may be the problem for two problems. It may be because of the pharmacological problem. I usually was injecting the micro droplet corticosteroid, or just have an particles which is more than bigger than the RBCs, and make many dissection for the cases for cadaver. After this, they found that brain infarction or basal ganglia infarction. So, and second thing is the thinking about the abnormality of the anatomy. And it may be not just injected intravascular, it may be just a dissection of the artery. It may jeopardize the blood supply or spinal cord. And because of that, they restricted to use a transforaminal, because many devastating complications happen in these 2 years. And 2011 or 2013, 14, just regress the role for transforaminal. And after ultrasound innovation and the higher technology and the higher resolution, they're thinking seriously about to make a selective nerve root block, not in the framing, just more lateral to the nerve. And, you know, started slowly with some complication, need a comparative study. Now it is a settled, evident, it's called structured, bring a good result to make thousands of cases here in our society without major complication. So this is was a complication to make a cervical epidural. This is a big picture by CR. This is the posterior anterior lateral view. And this is what's called transforaminal, just to go around the nerve root, and they injected the medication. And this picture gives you a very good safety, because I don't see the skin. I see the skin, or just I don't see the skin. I see just bone. I put the needle in the target area, and without looking, what is the structure between the skin and the bone, and this is very dangerous. So, and a very alternative for radicular neck pain, it may be radio frequency, can be used in some cases, very little cases, spinal cord stimulation in some cases, many invasive surgical modality, and surgical intervention. This is a pyramid, and this man touching the top of the pyramid is not me. What is the indication of our case to make a cervical epidural? It is a radicular neck pain, failure of the medication not bringing a result. This is a patient not candidate for operation. And MRI evidence of the cause, I found the cause by MRI. No contraindication, no coagulopathy, no diabetes, not pregnant. Good hospital facilities, and good experience about the procedure. And this is really important. There is some word by Chen GC and his colleague about the anticoagulation drug. And they found also selective serotonin reuptake inhibitor can make an anticoagulation like other drug, and selective noradrenaline reuptake inhibitor. So, and also low dose of antiplatelet therapy, non-steroidal anti-inflammatory can causing some coagulopathy. What is the contraindication for the case? If I want to do it, absolute, revision refusal, and also red flag. But other thing, it can be done with special requests for bacterial infection, systemic organized. This have some details, but it can be done. The only absolute contraindication is the patient refusal. And even in some cancer patient, it can do it if the cancer is away from the disease. And there is also a relative contraindication like allergy, pregnancy, because I can use a radiation. Now we can do it with pregnancy with ultrasound. Medication which increase the bleeding risk, and very important, because there is a guideline. There is no guidelines until 2014. After 2014, there is a guideline for pain, like for regional anesthesia. And because it's not depend on randomized control study, every now and then it changes. Also, hyperglycemia, immunocompromised patient, coronary artery failure, alter epidural anatomy, if you have a severe compromising of the anatomy by surgery or something like this, you can do it. A minor complication for this block, it may be post-dural puncture headache, can happen. various severe neurological disaster, major complication, post-spinal headache, and various severe neurological disaster until those permanent cord injury, epidural hematoma, pneumotocephalus, air embolism, cervical epidural abscess, retinal hemorrhage. This is all this case, convulsion, coma, and death. All this recorded about after this case. Minor complication like headache, neck pain, facial flushing from corticosteroid, vasovagal episode happen, especially with women, about 15% of women. Nausea, vomiting, fever, hypotension, respiratory insufficiency, subjective weakness, vertebral abscess, and sometimes superficial infection, which is very rare. And because I speak about risk, you are a predicted risk. You are just playing with a shark all the time, and some complication is fatal. So take care about everything about that to decrease your incidence. A combined spinal epidural injection, I just bring the patient to the OR, I get a consent and explanation and revision about, and to have an educator to educate the patient, the follow-up after injection. And I revise everything, lab, coagulation profile, MRI, and medication. And you must revise because sometimes you give a patient appointment after 1 month, and when the patient come to you, become completely free. So you must revise everything and revise his pain, and you can cancel the procedure. Again, what I do, injection of the steroid, I give an IV cannula because any disaster can happen. Monitoring, like an standard ASA monitoring, and patient positioning. Sometimes I make it prone, sitting, lateral, but all the time I don't use a heavy sedation. And sitting, usually I don't use a sedation. And very rare to use a sedation. And if you use a sedation, it must be patient cooperative with you to guide you for the pain because you don't see the pain. And I put a sterile preparation. The patient was sitting, and the operating room was all resuscitation facilities, not a simple procedure. And also there is a debate about, and I will show the video about that, debate about corticosteroid particulate and non-particulate. And after this event, they don't use, most of the pain community agree about not to use an particulate corticosteroid above the clavicle. Now we use an non-particulate like dexamethasone, and most of the studies showing they bring a good effect. And there is also a debate from FDA about the epidural corticosteroid and the value and the complication. And I attend one of the session about the pain community and the FDA. The FDA don't like because they revise all the complication from time of debility 1934 from the first epidural and found some devastating complication. And at that time, the needle is not well organized, and the sterilization, the medication. But you know what's written in the book, you can't delete it. And again, about the pain community, which is speaking about the good result. Sometimes you don't find any solution for the patient, we must do it. And I'm telling you a very fantastic thing. This at the time for 2014. And from mid-2013 to mid-2014, during this debate, about 10 million American did an epidural. And even the FDA community is still not agreeing about that. And this is a video for, I was doing a study at that time from this ABAD, what's called acoustic pressure assisted device. This can guide you for the epidural space, and he depend on the feeling like an آية in Quran إن السمع والبصر والفؤاد كل أولئك كان عنه مسؤولا. Just depend on this idea. Use your feeling, your eye, and your hearing. And hearing is most powerful thing. So you can guide it for yourself to go for the epidural space. And this is not the patient. And if you notice here, at this time, I still was using an particulate form. Is an particular. I never see the complication, but you don't need to see the complication to believe in it. But at that time, this is not my case. This is another case. We just make a study about acoustic pressure assisted devices. A device can choose a epidural. I make a comparative study between droplet technique or loss of resistance technique and the ABAD. And this was a very good result about, and this is published in cervical epidural puncture guided by fluoroscopy in comparison to acoustic signals by this machine. And this is published in Saudi Journal of Anesthesia, me and Dr. Hassan Ali, Dr. Yasser Tolba in 2017. And I will not speak about the machine because this is like a commercial thing. What happened to our patient? It was an operating list. Sitting position, I use the pad because of my study and the patient agreeing about the study. Needle in place, I put a needle in the cervical area by assisting of the image intensifier. And I make a dye injection. And when I make a dye injection, I found something happen. I will show for you now what happened. And the first, no blood come out from the needle. But with gentle manipulation for the needle, I found pulsatile blood coming from my needle. So just I will just show something happen. Dr. Saad, how can I make an? It's this one. You see this one? You see? Dr. Saad, anyone answer me? Is this picture? You see what happened?
No.
Yes. Yes, it's clear.
You see the when I injected the dye?
No video.
No
Video
video.
is not playing, but the picture is clear.
For the injecting. So I just make and I want to make a share for this. How can I make a share for this one?
Just play it on your screen.
So none, but it's okay. So how can I bring the screen, the mini screen, just somehow? I just will show for this for you.
I think you should stop sharing this PowerPoint and play your video.
This sharing, your share, yeah. This is the one. You see that now?
Oh yeah, it's coming up.
Yeah, you see what happened? Just like a circular thing in the neck. And when you inject a dye in milliseconds, this dye disappears. You see that? You see or not?
Yes, it's apparent, Dr. Yasser. You can repeat it again for other people to notice it.
Yes, you know this one. It's okay. So you see after that, I am sure this is what's your diagnosis? Intra-arterial injection, and this is first time for me. They happened to me. So I'm sure about from this picture. This is my picture after that, because this is something I don't see before. I don't read about it. So it is the intra-arterial placement of the epidural, and this is the neck, and the intra-arterial is high pressure vessels. So this is my picture. This is how I feel. And I search in my brain about the hundreds of courses I attend, hundreds of books I read, hundreds of cases I make, but I don't find anything how to deal with this patient, with this case. But I remember safety is first. Safety is first all the time. So I look for the triangle of quality to save the life, or to save the life with the procedure done, or to save the life with doing the procedure in maximum quality. So what I'm searching to save the life only. Because if your patient in a good quality of life, you are happy. If his bad quality of life, you are not happy. So what do you think now? To continue the procedure or to stop the procedure? And on what basis, if you do that? You know, for me, it was a panic attitude. I don't know anything. So what I did, I looking for my brain to see any map about anything or any information I don't found. And you see this blank slide is my experience at that time. I don't have any experience. I don't have any experience. I don't have any information about that. So this is not a wrong slide. This is like a blank slide because of I don't have anything. So I thinking seriously about the anatomy and the variation of anatomy and the imagination various reality. This is what we see an image, and this is what's the reality it happened. It can injure any vessel from these vessels. And I look for my anatomy, ascending cervical, or just an deep cervical or inferior thyroid or vertebral artery. What happened? So I just go for internet. I remove the needle. And I inform the patient about everything. This is one of our nurse. And I tell her instead to go home, you must stay in the hospital. And I speak with the radiology department, with my boss for neurosurgery, to be ready for any events. And the patient stayed for around 2 days in the hospital. And the radiology tell me no need, but if anything happen, we'll just make an MRI. And I was lucky because nothing had happened for the patient, and this is not the case all the time. And you know that the patient went home, and for me, I just went for the internet to see what's going on and what happened, and to search about any management if it's happened. I don't found anything because there is no guidelines like other thing. And also, what I found, I'm just read a lot about this. Every paper, everything to read about this. So, you know, in the cervical areas, there is a 10% of the cases you have a saccular AV malformations, what's like a saccular, what's injected inside. And the problem with high pressure, it can bleed and can make a catastrophe because this is a small area. And this is McLean. And also there is a network of arteries. Sometimes the vertebral artery is arthritic inside and make many connection, many saccular formation. And this comes from Hunton, from anatomical dissection. And also there is an arterial versus venous. Venous usually is a low pressure and can pass without any problem, but with arterial in a small area is very dangerous. I think seriously how to decrease intravascular or intramural injection. There is many things to do for that, but still complication happen. Like use ultrasound guided to see the vessel before, fluoroscopy, digital extraction, but already you are inside the vessel and injected to see the dye, compatible contrast dye, very small dose of local anesthesia or increment, no particulate steroid, laminar approach, a weak patient with minimal sedation, avoid transforaminal epidural, MRI review, and avoid epidural above C7. But you can do all this stuff, but you still have a complication. Avoiding intravascular injection, also there is many study about narrows in an ultrasound, just to use an ultrasound in selective nerve block. The accumulation of blood can happen very fast and can kill the patient, Shan Ching in 2014. Catastrophic or even of cervical hematoma, this can lead easily to this. Anticoagulation and epidural, the fact that the only in an American registry in 2013, 2014, 49 cases, they found only 1/3 of the case have a coagulopathy, but 2/3 don't have any coagulopathy. This is Moinita. There is an interesting study about the incidence of lumbar epidural hematoma. You know what is the incidence? What we know the incidence 1/180,000 or whatever. But really it happened 28% of the cases have an epidural hematoma after lumbar epidural. But the clinically manifested epidural hematoma, because low pressure, which happened is a very significantly less because it happened all the time, about 1/3 of the cases. And this is this is the difference between arterial, which disappears in millisecond, and this is the venous. This 3 pictures. This is not one picture. This 1, 2, 3. This taken in about 1 minute. But so the venous can stay for a long time, can stay. And this is a picture for digital extraction. And this is what I'm speaking about. This is like a saccular aneurysm or in the neck. So just I went for the evidence. Even the evidence, we know that the marriage is the main reason behind divorce, and this is the evidence based. But I don't found any human study. Few case report, if any. I don't find any case report like my case. Some animal study, and when you don't found anything, just to go for opinion of expert. From the evidence, I don't know what happened, but I know this is must occur for a beautiful lady because all people jumping inside this, going to this engine. This is, and also I can't make a study for this catastrophic events. I can't make to use a parachute and non-parachute to prove that parachute can save a life. So at this time, go for an old people because they bypass the exam, medical exam without Google, like we did now. So just I search everywhere. I ask my colleague. I found some study, but just speaking about only animal study for devastating complication of injecting epidural. And I found many particulate versus non-particulate. And major risk, this is a very interesting thing. He said the epidural don't have any value, and if they are not approving. And but if you're looking for the community, what you're writing, you can find the surgeon. But here in this paper, they found that the epidural is very effective and very cost effective and make a good result. And ultrasonography to evaluate the vascular access, another study to showing that how can you decrease it. And safeguard and prevent complications. There is a consensus, and you must adhere to this guidelines. And many paper, but nothing like my case. What happened cervical arterial in the neck. I found many cases like transforaminal, they found the injection, but transforaminal is still not risky like interlaminar. Transforaminal, the bleeding will be outside mainly. I found a vent to escape. And second thing, it may be injures the spinal cord but from the lack of, like an end organ. But you know that what happened to my patient? After that, the patient is still sticking to me. And she came after 10 days. They did the procedure. And I ignore one word from the surgeon. He told me that you can see the picture. I make the picture about in the level C5, 6. And usually I don't do that. I make it 671 or just 5, 6, 7, because this is a big area by the anatomy, we know from the anatomy. And with flexion, it may be 3 to 5 mil. But I make it up because the radiology was a very professional. He told me that there is a funnel shape, second ligamentum flavum at this level. So at the second time, I just went for the area and I found the picture. So I will show the picture, what happened in the second time. The procedure done after 10 days, beta score decreased from 10 to 2. Physiotherapy to improve the muscle spasm and wasting. She's okay now until 2014. And she wanted to come, she will stay for 4 years and okay, just on and off non-steroidal. And she wanted to come to me to make another procedure, still trusting me, but I escaped from here because I don't need to live this experience again. And I don't need anyone to live this experience again. So this is a real patient. This is the one I make it second time. It was in the study also. But at this time, I just went for a level blow. And I found what the radiology, when you work with a good radiology, he can describe in a way. This is a patient. He can describe in his way, this is what's called funnel shape, a structure of ligamentum flavum. This is a case, real case. And here you can see the dye in her neck. You see? And this is the one. You can, even after 10 days, you can see the dye here. Still some dye in this level, what I injected before. You see this dye? It may be injected the tissue, we don't know. So this time I go 67. And you know, when I injected what I found, this is a funnel shape structure, which described me. I just went up before because it's an open area. But here they described me, this is a funnel shape, and I found the funnel shape. And here, when you see the distribution of the dye, here you can see posterior anterior view of the distribution. So my message, a doctor is a student till his death. And when he feels to be a student, he will die. This is a physician, William Osler from Canada. So what my conclusion about this case report? Complications still happen, whatever you do. If you stay in home, you will not get complication. But if you work in the medical field, you will get complications, sure. And complications still happen. But we need from you to diagnose early, to ask for help all the time, as I ask for all the people to be ready for any events. Predict the worst. Don't see it will be, everything will be okay. Just predict the worst and just make a pathway for every worst thing. Create a pathway for management. You must make an, after that, it changes me and make a guideline and make an everything, because it can happen. Some precaution can decrease vascular and neural injury, and you must use all this precaution. And the role of media and the techno anesthesia and pain communication, it helped me a lot to understand what happened and to see what happened and to communicate with other colleagues in the same field, to communicate with the people and to bring all this stuff. So all the time, use all the capability to make your target. And this is very important. I know some of you just waiting for me to finish like this cat, when just an anesthesia doctor just waiting the surgeon, the lazy surgeon to finish. But I'm just telling you that what happened to me, there is a two pain in your life. Pain, which hurt you and teach you, and the other pain which change you. And is my presentation awesome, outstanding, or magnificent, usually all above the above. And thank you very much for attending my lecture. And I hope just to share my experience with you in this case. Thank you very much. And for any question, you can ask Google, because I don't know a lot about this case, but you know, I read a lot about, so I can answer you some of your questions.
Thank you very much, Dr. Yasser. It was very, very interesting and very, very funny. And you have many comments about how funny and how interesting the lecture is. So we have 5 questions. The first one is from Dr. Shahid Hafiz. He says, which steroid is safe in the neck?
You know, as I told you, and from 2008, 2002, 2008, they use most of the time, even for me, the first case I was using an depo-form corticosteroid, because our belief that depo-form can stay more. But most of the emerging study after that showing that corticosteroid can be comparable to this depo-form, because the particle is more than the size 3 to 5 times the RBCs. It can make a clump, and can make a problem for the patient. And most of the pain community, without a great evidence about that, except after this events, and they use an corticosteroid non-particulate like dexamethasone, they found that the incidence become very, very less about the complication. So most of the community all over the world now agree about above the clavicle, no day before. And even there is some study about the lumbar epidural. Most of people just use an dexamethasone. I use now dexamethasone. I don't find any difference. Non-particulate.
Okay, great. Thank you very much, Professor. Yes.
Yes.
Now you have a request from Hala Abdel Naim. She's asked at the YouTube link.
What?
Now there is another question from Elisa Shahali. She says,
Yes.
what is...
I don't
Yes,
understand.
so the question from Elisa Shahali. She says,
Yes.
what is the area, what if the area is punctured wrongly and in the wrong site? Will that lead to coma, death, or fatality? And what is the percentage of that happening?
What? Again?
Again, so Elisa Shahali is asking, what if the area that is punctured is punctured wrongly or at a wrong site? What if the cervical site is wrongly punctured? Can it lead to any coma or fatalities? And what are the percentages that this condition may happen?
Yeah, the first thing I will just answer from behind. The incident to happen, it depends on the expertise of the interventionist. So
Sure.
there is many studies showing about even spinal anesthesia, if it's done by a senior or by junior. This first thing. Second thing, very easy, very common. It can go to the fatality. I tell you that from 2018 to 2008, about 28. And if I tell you 28, you can multiply in 1,000 because not in every case just recorded in the internet. So it can happen.
Yes.
Can happen, and sometimes this is serious complication, and there is events how to decrease this complication, you know. But it can happen.
And this is why this lecture is very, very important, because all anesthesiologists, young and old, need to know the importance of how to manage anesthesia toxicity, local anesthesia toxicity, or even steroid injection, inadvertent injection. You have another question from Muhammad Ayasa. First of all, he thanks you very much, and then he is asking, what if this happened again? Will you remove the needle and end the case? Or just withdraw the needle a little bit and inject your medication for block, especially that you're using a small needle for the block?
Muhammad is our senior resident, is a brave heart, you know. For me, I learned the lesson. When I remove the needle,
brave heart, yes.
You know, when I removed the needle, it was an panic attitude, not just depend on evidence. But when I asked all doctors and all the people in the community, and I found the literature, you must remove the needle because this is on high pressure, and you can't leave the needle because high pressure and can make a catastrophic events. So it was right, but I was not depend on any events, but it was right. What's called panic attitude. So at any time it would happen, you must remove the needle and speak with the call for help. Neurosurgeon, radiology, and all people to be ready for any events to happen. This is what you can do. It can happen again. And this is what I learned, to remove the needle and to inform the patient and to put the patient under what's called close observation and to ask for everyone for help. And not to inject it.
Yes, of course. And it's following the ASRA guidelines as well. ASRA.
I don't hear you.
Yes. Now we have one more question, Dr. Yasser. It's from Abdul Rahman Yasser. He says, what is the complication that may occur if... Yeah, he's your son. MashaAllah, God bless. So he says, what is the complication that may occur if any bleeding happens during the injection?
What's the complication? That you know that, as I told you, maybe, and this is an interesting study for radiology, they found complication will happen in 1/3 of the case, but most of the time it is a venous plexus of Batson, and this is a low pressure, it can stop immediately. But for arterial, it can lead from neurological complication if you don't catch the patient early, especially in cervical, because the area is very tight and bleeding can make a catastrophic complication. It can, if you don't catch it early, if you don't ask for help early, if all the people not ready for to get engaged in your case, it can lead to this. And there is many cases record about this after epidural, even thoracic epidural. I found a case after thoracic epidural, a case of death, and after dissecting the body, the cadaver, or just the body, they found that the thoracic epidural extended to cervical area. And this is a vital center in this area, can kill. From convulsion, neurological manifestation, it can kill. So bleeding is catastrophic, especially if
From Hilal Siddiqui. This is the last question. He says, how often you can repeat this procedure and the age of patients is important?
You know, now you just we shift our practice now to ultrasound. We found the same result or maybe good result, and I see everything. I see radicular artery. This is a problem with the radicular artery. So there was thinking about previous anatomy, because the anatomy was studied in the university. It was a fixed science. Now it's not fixed. They found a variation in most of the area, about 30%, even more. Lateral cutaneous nerve side, the variation is about 50%. So now, if you look by ultrasound and see the radicular artery, usually you're thinking that anterior, most of the time, 2/3 anterior, 1/3 posterior. So you can see where is the artery, you can avoid the artery injecting around the nerve. Nowadays, just I don't do about more than 1 year now, I don't make a cervical epidural. I make a selective nerve root block. And the result is comparable, the same. The procedure is very easy. You don't need an OR like before, and you need a recovery. It can take a few minutes, and no radiation, no little cost. And we make about hundreds of cases. Even I was speaking with my fellow now. He's in the third year of fellowship. I tell him, just you make a very big amount of cases and very advanced cases, even in first year, because if you have the experience, the complicated procedure become very easy procedure, you know. So nowadays I don't make it because I'm not scared about the procedure, because I make many procedure after that. But I learned the lesson. I was caring about everything.
Yes. One more question, please, Dr. Yasser. It's hopefully this is the last one, because we need to start with Dr. Islam. The question says, was the patient in need for ICU admission? It's by Ahmed Nasr.
Not an ICU admission. I just put here because the ICU cost is very high, and but we put here like an intermediate care. This is like an in the department. It's just a one-to-one observation in the department itself, and this patient is observed for 2 days. And I ask for immediate MRI, but the radiology we can like a committee. The radiologist tell me no need, but anything if it happen, and just give her our phone, and if everything is happen, just asking you to make an immediate MRI, because it takes a few minutes to make it to go down. So this patient maybe need a close observation, but you don't need an ICU because it's not a critical up to now. You predict it to be critical, but it can be or can't be. But you know the prediction is very high. But I was very lucky, and the patient was very lucky, because you know that is a catastrophic.
Yes. Abdurrahman Yasser has another question. It says, what is the main indication for patients to make such like a critical procedure, and what other procedure or options that you can do for such like patients? What was the indication for this, case in particular?
Yes, you know that is a very important question, because you know that you tell me why you do this very serious procedure and for such a patient. Why? Because the patient, he don't have a quality of life. She can't sleep, have a severe pain, she can work, and all the time crying from this pain, affecting her quality, affecting her psychology, affecting everything, even social activity. The patient is not living. So if you found everything not working with the patient, and I will tell you a very good news, that the conservative management, it can work for 80%, more than 80% of the people, but you still have patient not relieved by anything. And you know, once the patient accepting to put a needle in his neck, he's in severe pain and agony.
Yeah.
It means the lumbar epidural, everyone can accept it.
Yes.
A needle in the neck, very rare people to accept. And when he accepts, you know that he have a severe pain and not controlled by SN. So I do this procedure because the patient have no pain, he's not alive.
Pain, yes.
He need to control his pain. So
thank you very much. Dr. Adel has a question.
Yeah, please, because thank you so much, Dr. Yasser, for this wonderful lecture. I want to ask you, dexamethasone, preservative free, or doesn't matter? Dexamethasone.
Yeah. You know that I'm telling you that when you speak about morphine preservative free, When I was saline preservative free. Do you have a free preservative free saline? Do you have an ibuprofen? The half-life of ibuprofen about 6 months. When you bring it from outside, it will be expired. So most of the people, even I speak with working with Dr. Omar Tawfiq, Allah forgive him, he telling me that all people speaking about this, but not you use it. You use it. Usually you use an corticosteroid you have, but you know, some companies very bad. You bring some days from India. It was a very bad one and get turbid and not clear. But we use in all practice. Most of our colleagues just you can find this book, but in real practice, use what we have in dexamethasone or whatever.
Can use hybrid technique combination of fluoro and ultrasound.
You know that he went I just started ultrasound experience in 2006. When the ultrasound like an you know, like a TV black and white with antenna, adjust antenna, you see like this. So what I found now, this is a high technology. I can see everything in his way, but still our resident or just a fellow telling me that I don't see anything. You are just shitting. This is black and gray, and you tell me this is a nerve, this is the artery. So what I'm telling you, when we're starting our practice for many years, for 2 years at least, I use the ultrasound with image. I bought the needle by ultrasound and examine the image. And after you get a good experience about the procedure, you know where are you, you know where is your anatomy, you know there's a variation. For about 4 years now or 6 years, I don't use anymore the CR with ultrasound. And even in some private hospital I worked for about 6 years or 7 years, it was uncostly. You can't use the two modalities because the insurance is not paying for you. So now most of the time I use an image only for something behind the bone like an epidural, but most of the procedure I did it and the same result, what I feel, and we have many studies run about that. And you can find, you know, from 4 years to now, all the everything changed because the experience become more, the technology become more better, and the mega what's called the resolution become for the ultrasound become very great, you know, now.
Yes, and I always say that young residents now are very, very lucky because each anesthesia department around the world have an ultrasound machine and mostly up to date.
Yes.
Older generations didn't have this luxury, so you should be very thankful that you have ultrasounds. We used to do blocks blindly. Thank you very much, Professor Dr. Yasser Rida. Thank you very much, all the panelists. Now we will move on to our next presenter. He is Dr. Islam Ramadan. He's an anesthesia fellow in the liver transplant and hepatobiliary surgeries. Dr. Islam has an MD, DESA, EDAIC, FCAI. He was an Airway fellow, anesthesia department, Beaumont Hospital, Dublin, Ireland. He's a college tutor for final year medical students and Airway instructor in Royal College of Surgeons in Ireland, RCSI. He's a lecturer also in Ain Shams University hospitals in Cairo, Egypt. He has a special interest in airway and pediatric anesthesia. Dr. Islam will be giving us a lecture today about airway obstructive airway management, and the mic is all yours, Dr. Islam. Thank you very much for your great time. Please,
thank you so much, Dr. Ines. Thank you
any
so much for
questions,
your
please post it after your lecture.
yeah, okay.
Go ahead, Dr. Islam.
Thank you for your lovely words and your introduction, and I want to thank all the committee behind the mega course who give their time and effort for this course, and I'm honored to be a speaker in this course, really. Thanks for all of you. So I will share my slides here. So our lecture today is a hot topic talking about management of upper airway obstruction. So hot topic during the exams and also in our clinical practice. So the objectives of these lectures will talk about decisions when and how you will do intubation for upper airway obstruction and what other alternatives for that. Airway assessment, quick review for that, and some definitions about it. Systematic approach of management of airway obstruction. And these 3 points will go through a case scenario to make it more interactive. And at the end, we'll talk about briefly about the guidelines for awake tracheal intubation 2019, and can't intubate, can't oxygenate scenario, and the front of neck airway access. So if we talk about this case, imagine you have been asked by the A&E registrar to review a patient in the recess, 66 years old woman who is presented by difficulty of breathing and stridor, with history background of obesity, high BMI, COPD, and pharyngeal squamous cell carcinoma. So what is your reaction and what is will come in your mind while you are going to check this patient? Of course, all anesthetists, when they hear stridor, you have your heart rate will come up and you will be more alert and worried about the patient. But anyhow, as we said, this is one of the most frightening situations that the anesthetists may encounter, really. And I want to emphasize that there is no universal guidelines or best approach for management of upper airway obstruction. Your management will depend on answering two questions: is when I will secure the airway? Is it an emergency that I have to do it in the A&E or in the ward? Or I have time that I can optimize the patient, I can shift the patient to the theater. So it will guide your management for this one. The second one question is how I will secure the airway. So is it a conventional induction and intubation, or I will do awake tracheal intubation, or the patient will need tracheostomy? Usually, you always you put plan A, plan B, and plan C for your patient. So intubation is based on 3 fundamental clinical points. All of us will know about this one. The first question is there a failure of the airway maintenance and protection of the airway, like low GCS less than 8, in traumatic brain injury or in intoxication? Is there a failure of ventilation and oxygenation, like status asthmaticus or COPD exacerbation? And what is anticipated clinical course? And this is very important and really depend on the experience of the anesthetist. For example, like stab, neck wound, polytrauma patient, angioedema, and burn. Those kind of patients can be presented in the A&E asymptomatic from the point of view, airway point of view, or mild symptoms, but suddenly they can be rapidly progressive and you have complete airway obstruction. So you have to be ahead of them and anticipate the progress of this disease. Any action are required before performing actual intubation. So you have to, according to your assessment for the patient's need of intubation, as we discussed in the previous slide, and the urgency of the situation, determine the best method of airway management based on your assessment, and we'll discuss this one in the coming slides. Decide what pharmacological agents are indicated, what order, what doses you will use, and prepare a plan in the event that the primary method is unsuccessful. And this is a very important point. And this is my advice for all the attendees, that you usually have plan A and plan B if the plan A is not working. So how to approach the patient or your assessment? So the first thing, be sure that there's an airway patency, and this can be confirmed easily by asking the patient, what's your name? Do you know where are you? If he's answering, he has a patent airway. Assess your airway. We'll discuss this one in the coming slide, but quickly, if there's like limited mouth opening, like short theromental distance, like this little microgantia and short theromental distance, limited mouth opening. Third point is to assess the ventilation, and this can be done simply by taking ABG to see the PO2 and CO2. Assessment of patient anticipated clinical course, as we mentioned before, like angioedema. This patient, of course, rapidly progressive. It will be a difficult scenario if you are going to intubate this patient. So in terms of airway assessment, there's some useful mnemonics for difficult or assess difficult laryngoscopy, difficult bimanual mask ventilation, difficult LMA insertion, difficult cricothyroidotomy. So if we go for the difficult laryngoscopy, we are usually we can use Lemon score. This is L for look externally, and usually if there's an official trauma, beard or mustache, big tongue or prominent incisors, and E for evaluation, 3, 3, 2, 1. So 3 fingers here for the mouth opening, 3 fingers between the mentum and the hyoid bone, 2 fingers between the hyoid bone and the thyroid. And this 3-3-2 rule is to be sure the alignment of the pharynx, larynx, and the trachea. All of us, of course, we know the Melamphatic score, opacity and obstruction, neck mobility. Roman for difficult bimanual mask ventilation, radiation or restriction of neck movement, opacity and obstruction. This lady, you have to be sure that the mask to be fitting and sealed on the face. Old age, no teeth, also all these parameters for anticipated or bimanual mask ventilation difficulty. Rods for difficult LMA insertion, again, radiation, opacity, distorted airway, short theromental distance, and smart for cricothyroidotomy, any surgery in the neck, mass, a distorted anatomy, radiation, or tumor. And this is an example. Of course, this case, it's nearly impossible to do any cricothyroidotomy or tracheostomy. It's a very difficult case. We have 4 key signs for upper airway obstruction. I don't want you to forget it, which is muffled or repetitive voice, inability to swallow secretion, stridor, and dyspnea. These 4 key signs for upper airway obstruction. The first 2, it doesn't indicate that there is a complete or nearly complete upper airway obstruction, while if the patient is stridorous, be sure that it's more than 50% of the airway is obstructed already, and it's a serious condition. We'll go for some definitions. So if you ask me what does it mean difficult bag mask ventilation or difficult laryngoscopy, so we'll go one by one for this one, and there is no universal or total agree about these definitions. They are different in many literatures, but I pick the most common definition that we are using. So difficult bag mask ventilation is inability of unassisted anesthetist to maintain oxygen saturation above 90 on FiO2 100% or FiO2 or difficulty in maintaining mask seal and obtaining satisfactory end-tidal CO2 and tidal volume. The incidence of difficult mask ventilation is 1 to 2 per 100, and the incidence of impossible mask ventilation is 1 to 2 per 1,000. Difficult laryngeal mask ventilation, inability within 3 insertions place the laryngeal mask in a satisfactory position to allow clinical adequate ventilation and airway patency. And when we are talking about clinical adequate ventilation, we mean that tidal volume of 7 ml per kg and peak pressure not more than 15 to 20 centimeter water. And the failure rate of LMA is around 2%. Difficult laryngoscopy, it is not possible to visualize any portion of the vocal cord after multiple attempts by direct laryngoscopy, the conventional one. Difficult intubation is difficult or failure of to do tracheal intubation or tracheal intubation require multiple attempts in the presence or absence of tracheal pathology. We'll continue the case. So you went and you did your physical examination, which revealed that patient is somnolent but arousable, working hard, respiratory distress, supraclavicular and suprasternal retraction, and you can appreciate really high inspiratory stridor. And when you are doing your airway assessment, you have a limited mouth opening beside the high BMI. So we have many points here that indicate or predict difficult airway management, high BMI, limited mouth opening. You have a mass which led to respiratory stridor. And from this working hard criteria and somewhat expecting that the patient start to have some sort of respiratory failure as well. So we'll highlight some points on stridor, which is a harsh monotone airway sound produced during airway flow through an obstructed airway. Stridor may be high or low pitched, may be audible by bedside or need to be auscultated, and maybe inspiratory or expiratory or biphasic. Again, as we said, stridor, meaning to say that more than 50% of the airway is obstructed, especially in pediatric population, and anxiety, coughing, crying may lead to total collapse of the airway. From the pattern of the stridor, you can detect or determine the level of the airway obstruction. So if the patient has inspiratory stridor, most probably the obstruction is in the upper airway, as you can see here. While biphasic stridor, it is mid-tracheal, while expiratory stridor is lower airway obstruction. So to give you roughly where is the obstruction. So the causes of airway obstruction, we can classify it according to anatomical location, glottic and supraglottic, subglottic, and mediastinal or intrathoracic. And tumors like tumor epiglottitis, deep neck infection, anaphylaxis, angioedema, foreign body, and there's a lot of reason for this one. So you decided for our case to do an ABG, which revealed respiratory acidosis with good oxygenation type 1 respiratory failure. Endoscopic examination revealed large friable mass fill nearly the entire pharynx and supraglottic area, unable to visualize the vocal cord. The patient is in a semi-seated position, working hard, and high flow oxygen cannula. Out of concerns of the upper airway obstruction and respiratory failure, you decided to secure her airway by doing intubation or securing the airway. I want to also to emphasize about the endoscopic examination or what we call nasal endoscopy. Usually, in the elective list is done by the ENT or head and neck surgeons in their clinic if patient have any supraglottic or glottic tumor. But I recommend if anyone has patient that presented by there's an emergency of upper airway obstruction or even in the elective list and suspect difficult intubation, it's very simple, just local lidocaine spray, nasal lidocaine spray, go by the fiber optic, okay, very gently, just to see the vocal cord and localize where is the mass, to see the size of the mass, if there is any deviation of the trachea. It will give you indication about the success of the awake fiber optic if you are planning to do awake fiber optic intubation or other alternative like awake tracheostomy. And this is the case, as you can see, this is a tumor, supraglottic tumor, and you cannot appreciate the vocal cord. So it will be very difficult, even if by awake fiber optic, this case. So to secure the airway, we have 5 principles, and you should keep them in your mind while you are thinking how to manage the airway for upper airway obstruction. The first principle, I want you to know that the clinical picture dictates your action. So don't wait until the patient is hypoxic or desaturation to let you decide to secure the airway or to go for intubation. Usually hypoxia is a late sign. So your decision should be taken upon the clinical picture of the patient, your clinical assessment, patient respiratory effort and discomfort, and the kind or the pattern of the pathology itself. The second principle is avoid sedation and paralysis. So never take away what can be given back. It's critically important to keep the spontaneous breathing of the patient, not abolish it, especially if you suspect difficult intubation or backmask ventilation or surgical rescue for these patients. The third principle is keep in your mind that surgical management may be plan A. It doesn't necessarily to be plan B after you failed in the intubation and then do the rescue surgical management. It can be plan A from the start. And it should be done in a highly equipped area like OR, skilled anesthetists with you, and contact the head and neck surgeons to be beside you. Principle number 4 is buy time while examining the airway. And it's very important because you will take time, of course, to prepare the difficult airway trolley. You will call for help. You will need the assistant with you. You will call the theater to prepare for the coming patient. So don't do all of that, and you are examining the patient as well. So don't do all of that and you are leaving the patient as it is. No, you can do a lot of actions or procedures that can optimize the condition of the patient, give yourself and the patient time until you have a decision or management plan and prepare the environment for this. So what you can do, you can connect the patient to high flow nasal oxygen, setting up the patient, as we said in the endoscopic examination for the vocal cord, transfer to high critical area like theater, put the monitor, consider heliox in upper airway obstruction. And it's very important to detect the cricothyroid membrane and to mark it. Even theater, we encountered before many times that we failed to do awake tracheal intubation And we know this is very difficult to do with our conventional intubation. And the head and neck surgeons themselves, they are marking the cricothyroid membrane. Epinephrine nebulization, steroids, and reassuring the patient and decrease the anxiety. The fifth principle is intubation technique itself. Okay, so the decision how to secure the airway, it depends on it will go in three options. So the first option, you are using direct or video laryngoscopy with inhalation induction. So still you are keeping the spontaneous breathing. The second one is awake tracheal intubation, either fiber optic or video laryngoscopy, and again spontaneous breathing is maintained. The third option is awake tracheostomy under local anesthesia, and again the spontaneous ventilation is maintained. You don't want to be in a situation that you start IV induction, muscle relaxant, and you are trying to intubate the patient, you fail to intubate the patient, and of course, the hypoxia and desaturation will be a bad consequence. This is a protocol. I don't know if it's clear or not for all of you, but if we can classify the upper airway obstruction into two categories. The first category is patient that is already in like respiratory arrest or about arrest, and you don't have any choice or you don't have any time unless you're doing considered rapid sequence induction, attempt laryngoscopy. If you are able to intubate, well and good. If not, and in situation of can't intubate, can't oxygenate, you will proceed quickly for surgical airway. Okay, but if you have time and the patient is awake and breathing, okay, so your decision depends on your airway examination. So mild to moderate obstruction, airway obstruction, and you will be able to visualize the vocal cord by nasal endoscopy with minimal difficult airway character. We recommend to go for inhalation induction and using McGrath or video assisted laryngoscopy or direct laryngoscopy. But if mild moderate obstruction, you can still visualize the vocal cord, but there is a multiple difficult airway characters, as we said, like retrogantia, large tongue, difficult. The criteria that we said, difficult intubation, difficult mask by mask. So the recommendation here to do awake fiber optic intubation under topical anesthesia. The third category is severe obstruction. You cannot visualize the vocal cord, severe respiratory distress, and here you can go for awake tracheostomy under local anesthesia, like our patient. You will be able to visualize the vocal cord. So that's what we said based on the previous knowledge. The decision was to do for our patients awake tracheostomy under local anesthesia, and the patient transferred to the ICU for post-operative care after this one. So our usual post-operative management in the intensive care admission, routine post-intubation management, like analgesia, sedation, chest X-ray to detect the site of the tracheostomy or the site of the place the tube, ventilator management, blood gas measurement, and controlling the condition of the patient. And of course, if this is for further intervention, like depulping of the tumor or remove the cause of the stridor itself. So the next two parts is we'll talk about the guidelines for the awake tracheal intubation 2019. Awake tracheal intubation is considered the gold standard in management of expected difficult airway. The incidence of awake tracheal intubation from all intubation UK is 0.2%, which is low, and because this incidence is low, there's a lot of factors. One of them is the experience of the trainee and the doctor of the awake tracheal intubation, and the second part is the practice themselves. The key components of the awake tracheal intubation is stop, sedation, topicalization, oxygenation, and performance. And we appreciate this. The S is small because sedation is not mandatory to do or to perform awake tracheal intubation, especially if the case is an emergency, morbid obese patient, not preferable to do sedation. So as we say, sedation, awake tracheal intubation may be performed without any sedation. You have to weigh between risks and benefits of the sedation. The usual agents we are using remifentanil infusion or dexmedetomidine infusion. A single agent strategy is safest for non-expert anesthetists. for airway localization, and this is the main part, and this is and really this is the most important part, lead to successful airway tracheal intubation. Lignocaine with maximum dose 9 milligram per lean body weight. Nebulized lignocaine can be used, but absorption is variable. There is a different practice about nebulized lignocaine. From my experience, and it's not necessary to do nebulized lignocaine. The most important is to the spray itself in the either nasal or oral, and to have complete block for the oropharynx and the glottic area and subglottic area. Glycopyrrolate around 200 or 300 mic can be given. It's better to be given around 20 to 30 minutes before performing the aortic tracheal intubation. It minimizes or decreases the oral secretions, which help to absorb the local anesthetic, local anesthesia faster. In terms of oxygenation, there's a recommendation to administer oxygen during aortic tracheal intubation. It should be started as early as possible, the patient arriving to the theater. We recommend also the recommendations to use high flow nasal oxygen from 30 to 70 liter. The reported incidence of desaturation with this one is 0 to 1.5, is very low. In terms of performance, so selection of the endotracheal tube is very important. A lot of anesthetists they are not notice that how much is important this one, but the recommendation is to use a reinforced tube and stay away from our conventional PVC tube. The pivot should be directed posteriorly toward the posterior commission of the vocal cord, and choose the smallest tube as much as you can for your patient. Patient setting up, most probably if you are performing the tracheal intubation from the front position. Ensure the operator can see the monitor, screen, and pump, and there is ergonomics is very important during performing aortic tracheal intubation. Again, the aortic tracheal intubation can be done by fiber optic or by video laryngoscopy. After intubation, you have to check 2 points. You have to be sure that the intratracheal tube is intratracheal by visualizing the tracheal lumen if you are using fiber optic, or to visualize the tube going between the vocal cords if you are using video laryngoscopy. And of course, you have to see capnographic wave on the monitor. And I recommend all of you to have a quick look on the guidelines in details about this one. This is picture talking about the ergonomics of the aortic tracheal intubation. The operator is here, and this is the monitor for the patient. You can see here the video for the aortic fiber optic and the pump, so he can see the 3. If he's performing the aortic tracheal intubation from back, again, the pump is here, and the monitor, and the video and the monitor in front of the operator. This is what we talk about: oxygenation, performance, tubicalization, and sedation. So complication and failed aortic tracheal intubation. So the overall complication is around 18%, and mostly due to inadequate stop. Again, during the DAS guideline, you have to stop trying after 3 attempts, and 1 with the most experienced and senior attempt. Unsuccessful attempt is defined by unplanned removal of the fiber optic or video laryngoscopy or the intratracheal tube from the patient. And there is algorithm you can follow in case of failed aortic tracheal intubation. Again, this is the complication, how you can manage the complication in the stop. So if there is a problem in the oxygenation, you can increase the FI2, change the mode of the oxygen delivery. I don't want to go in detail for this one, but just to have a look on this one. And this is the protocol in case of unsuccessful aortic tracheal intubation. The third point is the can't intubate, can't oxygenate, and fauna. So the can't intubate, can't oxygenate scenario incidence is 3.75 per 10,000 anesthesia, and therefore identify the incidence of emergency fauna as 1 in 12,500 to 50,000 general anesthesia cases in UK. It is a part of the DAS guideline for difficult intubation, Plan D, the cricothyroidotomy. So the most important part in the cricothyroidotomy or the FONA is to detect the cricothyroid membrane. So all days or before, you can detect it by visualizing the anterior neck skin crease, and it's effective in 50% of patients, which is very low, or the conventional palpation, and the successful rate is around 70% in non-obese, 40% in obese patients. And they recommended from the DAS to use the laryngeal handshake to detect the cricothyroid membrane. The fourth technique is using the ultrasound. We'll discuss now the laryngeal handshake technique. It's a simple maneuver that you put your thumb and your index finger on the greater cornea of the hyoid, then sliding down to feel the two sides of the thyroid cartilage, coming more down to feel the cricoid cartilage, and then by your index palpate in the middle of the neck to see the cricothyroid membrane. So here this one coming down, and by the index to check the cricothyroid membrane. More prominent in male, more difficult a little bit in females. The fourth part is the ultrasound technique. We have two ways, either longitudinal or transverse technique. For the longitudinal, you will put the linear probe in the midline of the neck, and you can see in the midline exactly here, this is the hyoid bone, which is a hypoechoic part. This is the cricoid, and you can see like chains of beads here. This is the tracheal rings, and the hyperechoic area, this is the air line and the mucous membrane. This is the isthmus, part of the isthmus. Okay, so when you see this one, the next step is you can put a cannula, okay, which is again like a metal part between the cricoid and the thyroid, and the cricothyroid membrane, and then you can remove your probe and mark this one. You can use it directly, or in case plan A is failed, so you'll go for the surgical rescue for the patient. For the transverse technique, again, you can use linear probe. It's more difficult in prominent thyroid colors like in males, Adam's apple, more convenient in females. So this is the hyoid bone, and you can see here, this is the hypoechoic part, this is the two vocal cords, and this is the arytenoid cartilage here. So when you have this view, just you will slide down. So this is the view. I don't know, I make it more. So this is the horseshoe shape of the thyroid cartilage, and if you displace your probe a little bit down, you'll find hyperechoic line. Okay, this is the cricothyroid membrane. Displace it more down, you'll find here again hypoechoic. This is the cricoid cartilage above the hyperechoic line. It's like ring shape. So go up again to be sure that this is the airline of the which equalizes the cricothyroid membrane. And here, this is your point of insertion. This is the kit for should be used for in case of surgical rescue. It's very simple. Should be attached to each ventilator in the theater and in the emergency department. Tube, intratracheal tube size 6, can be reinforced or normal tube. Blade or scalpel size 8 or 10, bougie, and chlorhexidine for disinfection. So maximum extended for the neck. This is how to do the cricothyroidotomy, neck extension of the neck. Again, laryngeal shake, palpate the larynx, detect the cricothyroid membrane by this one or by ultrasound, whatever. Then if you can feel it, the cricothyroid membrane, so stab, rotate, insert the bougie, and then the intratracheal tube. Okay, so stab and then rotate, make the blade toward the foot of the patient caudally, and then insert the bougie, and then after that insert the intratracheal tube over the bougie. If you cannot palpate if you cannot find the cricothyroid membrane, so you can make transverse skin incision and try to palpate a small transverse skin incision by the blade and try to palpate the cricothyroid membrane. Again, rotate bougie and roll the intratracheal tube. So what I want to, at the end, to summarize what we said, the most important is to have plans in your mind. Airway management is not a single plan. You have the plan A, plan B, and of course, as a best guideline, there's A, B, C, and D plans for this one. So call for help, take your time, and if the patient is still stable, optimize the condition of the patient, buy time by yourself, and trying to do any surgical or intubation in a highly equipped theater, area like theater, with your assistant and specialized nurse for this one. Thank you so much.
Thank you very much, Dr. Islam, for your wonderful lecture. We have only one question from Khalida Radwan. She says, what to do if such a patient has COVID-19 and he is positive?
Of course, we stick to the local guidelines for your hospital, but during the era of the COVID-19, of course, it was not recommended to use awake fiber optic intubation for patient during the elective surgery. But as we are talking about emergency, I'm talking about our system here in Ireland. In the E&E themselves, they are separating the patient to COVID area and non-COVID area. And if you will transfer the patient to theater, there is a dedicated theater for COVID patient. And of course, all the personnel, including the nurses, the head and neck surgeons, will be with full gear from transferring the patient from the A&E to the theater. And according to, as I said, the local guidelines for us here, after doing intubation, we have to wait for 10 minutes, and then the surgeons can come to do the tracheostomy or the surgery. And if they're planning to extubate the patient, we have to wait, of course, after this one also. So, yeah.
Great. We have a few more questions, Dr. Islam. So we have a question from Dr. Muhammad Ahmad Ali Ahmad. He says, can we use 14 gauge cannula as percutaneous cricothyroidotomy? 14 gauge.
If you don't have any, of course, if you have the cricothyrotomy set, you can use the 14 gauge cannula for this one, but take care just to be cautious about to transfix the trachea going to the esophagus. So just once you feel loss of resistance, that's what we usually feel from the scalp or the blade. Once you feel loss of resistance, slide the cannula, remove the trocar, and you can start to either insert like guide wire and put the intratracheal tube after this one.
Yeah, another question by the same Dr. Muhammad Ahmad. He's asking, how can you ventilate the patient through the cannula?
Doing this one either by usually using like high frequency jet ventilation, like Manujet or Sonos, if it's available in the hospital. If not, depending on the apneic oxygenation, you just connect on high pressure of oxygen. But be cautious. This situation, even if you're using the jet ventilation, there is a higher risk for power trauma for those kind of patients. But if you don't have any other option, you have to use this one with cautious and at least pressure that you can use it.
Okay, we have another question from Dr. Asma Badawi. First of all, she thanks you for your lecture, as all we do. And then she said, do you recommend to give muscle relaxation in difficult intubation and easy ventilation? Do you recommend that?
Again, in difficult
do you recommend to give muscle relaxation in difficult intubation but easy ventilation, or no?
Honestly speaking, during our if the case is an elective case and there is an airway obstruction, I would say no, don't use muscle relaxant. Don't abolish the spontaneous breathing for this one, because you cannot guarantee that you can ventilate the patient after using your own spontaneous breathing, because after you put them sleep, the hypotonia of the muscles can collapse this area, the 40 or 30% remaining for this one, and sometimes you will not be able to ventilate the patient.
Okay, there is a question by Dr. Muhammad Ali Siddiqui. He says, do you have any scope to use video still late for facilitating awake intubation?
Yeah, this is the awake tracheal intubation, as we said, either fiber optic, which is the most most common before, but now the era is going for awake video laryngoscopy,
Yep.
which was proved by many studies that is easier even for the trainee to be more confident to use it than the fiber optic, and faster in preparation and easier for the trainee to get learned with this one. And the results.
Actually, you just answered the next question by Dr. Khalid Mohammed Abdul Latif. He says, which technique you recommend for awake intubation, fiber optic or inhalation induction? You just answered this question.
Or inhalation and induction.
Yes.
No, it depends on the patient, but you have to be ready for all. But if you are confident, and depends on that, and this is experience. If you are confident about the awake tracheal intubation, I recommend it strongly than the inhalation, of course, for this one. And we make a systematic review comparing between awake fiber optic intubation by bronchoscopy or video laryngoscopy. And as I said, the result is more towards the video laryngoscopy in terms of the success of the first tracheal attempt and the patient satisfactory for this one.
Okay, thank you very much, Dr. Islam. That's all. Naam.
Dr. Ines, please.
Yes.
If you don't mind, I want to comment and ask Dr. Islam one question.
Of course, Professor Aslam.
Thank you. Dr. Islam, you touched a very important subject today, because this subject is we are facing even every day, every moment in the OR or in the recovery, specifically with, as you mentioned, the stridor with the pediatric even. And we need meticulous and brave anesthetist, not to be in hurry or to be in panic. And I think the first step for management of obstructive airway management is to call for help.
Definitely.
For expert persons, specifically, we have in every hospital expert persons in the airway management, and we are doing a lot of workshops in the airway management. So it is not just to give my colleagues and my residents, my juniors a home message. It is not shameful, even for us, the seniors, to call for help for any problem facing in the anesthesia, specifically for the airway, because this is life-saving. Exactly. This is number one. The second one, if you please, the teaching process in our hospitals nowadays depends on the technology. And I am not against technology. Nowadays, as we listen from Dr. Yasser and our colleagues and before Dr. Hazem, we are using ultrasound in everything nowadays.
Exactly, yeah.
But I am stressing about the management and the intubation, endotracheal intubation. I see nowadays for our residents, they make it easy to use glidoscope, fiber optic, and they are neglecting using the usual and the traditional laryngoscopy. So I am stressing for our residents and juniors to know the principle of the intubation first. I'm not against technology. Like the laparoscopic or the robotic surgery, sometimes the surgeon, he knows the laparoscopic and the robotic surgery, and if something happened, he cannot manage by the traditional surgery. Maybe I am an old man and I am with the tradition, but I am using the kaleidoscope, but not to be as you. Every case, we have kaleidoscope. We may go for any place in our country or other countries or in the periphery, and we may not find the kaleidoscope or this technology. Are you agree with me?
Exactly, Dr. Assam. That's it's happened to me here in Ireland. What you are saying is really, because when I'm doing my airway fellowship in Beaumont Hospital, the protocol there is using McGrath for all patients using McGrath. And of course, this is better than laryngoscopy and more safe. We agree about this one. But once I transferred to Vincent Hospital, my liver fellowship now, I encountered difficult intubation. And the nurse, she told me that there is 3 McGrath only on the whole theater, and it was not available beside me. I tried 2 times and 3 times by the laryngoscopy. I was not able to visualize the vocal cord. So at that stage, I told her, but I feel when I'm doing this one after 1 year using McGraw, I feel still, you know, not the confidence, but you lose a little bit the skill how to do it, you know. Just for 1 year I'm using the McGraw. I'm not, of course, all of you are my professors, but 16 years in anesthesia, of course, you know. But it's very important to every now and then to keep your skills, basic skills, like the central line, ultrasound using central line. Every now and then, every 10 patients, I'm doing one anatomical like before. In our old days where I don't have central ultrasound for this one, just in case of emergencies, just in case you don't have it. Absolutely agree. And of course, the call of help, this is number one in the DAS guideline to call of help, and this is very important, very, very important. Even the help will be the same level of you or even lower, but at least will give you second hand for you.
There are two more questions for Dr. Islam, if you don't mind. One of them is about emergency situations like road traffic accident. If you have a patient that has a full stomach and is a difficult intubation scenario, what are the options available?
Spinal trauma or fascial trauma is a wide or broad topic, you know, according to where the fracture, if there's a fracture, if he cannot maintain airway. But of course, if the patient is full stomach, and you are going and suspect difficult intubation, you can do it by awake fiber optic. It's not a contraindication if the patient is full stomach. But the problem is, that's why if there's bleeding inside, it will be difficult by fiber optic because of the bleeding. It will,
of course,
yes,
you will not be able to visualize.
Exactly. So you can do it by video laryngoscopy. Will be more convenient if we be able to do that.
The last question for the night is the role of intubating laryngeal mask in difficult airway, and if there is a role of video assisting in difficult airway. I think you already answered the video assisting. Yes, we already answered the video assisting, so we will just give a hint about laryngeal mask.
Can I make one announcement, if you don't mind, please? Next Sunday, we have Prof. Hazim Yassin. He's going to talk to us about trauma rapid response team and ACLS. So it will be complementary to this lecture and complementary to the last lecture he gave already before, and he's with us today. And Sunday 13th of September, we have Professor Muhammad Al-Tahan. He is going to talk about his experience about video laryngoscopy in pediatric patient, pediatric obstructive airway. So this course, Mega Online course, will have a massive experience about regional anesthesia, pain, airway, trauma, and of course, the endless intensive care experience by our eminent distinguished speaker, Professor Samir Ansari. He's the top star of this course. And thank you very much, everybody, today. And I am overwhelmed by this attendance and the success of the night. And wish you well. And thank you very much.
Thank you.
Thank you. Good night.
Have a good night.